Hello everyone, my name is Jorge Viana and I will explain about obstetric operation to Project DMG. Yes, well, operative obstetric operations concept. Operative obstetric is a method used to deliver the fetus other than by means of uterine contractions and mechanic of maternal pushing. May include cesarean or vaginal, yes, forces delivery. The next topic is obstetric forces are medical instruments made of metallic materials that are used to give, rotate, pull, or both. At the head of the fetus, the classification for its use is exit, low, medium, and high. Exit is most often used. The fetus head is on the pelvic floor. Low. The head is below the molar stations and has not reached the pelvic floor. Medium. Of a little use. The head is below station 0 but does not reach more 2 stations. High. There is a risk for mother and fetus. The head is not engaged above station 0. Well, this is image about forceps delivery. Obstetric forces, yes. Indication are as follows. Prolonged second stage, more common for forceps, may be due to dysfunctional labor or suboptimal orientation of the fetal head. Category 3 EFM is electronic fetal monitoring, yes. So, category 3 EFM strip, the fetal heart rate suggests that the fetus is not tolerating work. Maternal pushing should be avoided. Pushing efforts can be dangerous for the parturient. Cardiac, pulmonary, or neurosurgical disorders. Bridge presentations shorten the time to get the head out of vaginal bridge presentation fetus. Prerequisites include the following: adequate pelvic dimensions, complications such as lacerations to the perineum, cervix, vagina, and uterus of the mother, soft tissue compression or head injury caused by incorrectly placed forced plates, fetal, neonatal. Operator must be experienced, complete the cervical dilatation, attached fetal ahead, observe the orientation of the certain fetal ahead. Vacuum structure. Well, the concept is about vacuum structure. A vacuum structure is a cup-shaped instrument that is held against the fetus head, taking advantage of the suction. In this way, traction is applied to the scalp of the fetus, which, together with the pushing efforts of the mother that help the descent of the head. The cups can be made of plastic or metal material, soft or rigid. A vacuum structure has some advantage over forceps: fetal head orientations, exact knowledge of the position and attitude of the fetal head not essential. Hip rotation occurs spontaneously in the best season. Head rotation occurs spontaneously in the best season, suitable for the configuration of the fetal head and the mother's pelvis. Space. The vacuum structure does not use space adjacent to the fetal head. Perineal trauma, 3rd and 4th degree lacerations are fewer. A vacuum structure has disadvantages over forceps. Cup leakage. Excessive pull can cause decompression as the cup suction is relaxed. Scalp trauma. There are injuries and laceration of the skin of the scalp frequently. Infrequent subgaleal hemorrhage and intracranial bleeding. Neonatal jaundice come from bleeding from the scalp. The indications for vacuum are similar to those of forceps. Prolonged second stage, this may be due to dysfunctional level of suboptimal orientation of the fetal head. Worrying EFM strip, FHR, fetal heart rate, monitor patterns show that the fetus is not tolerate work. Avoid maternal pushing, cardiac, pulmonary, or neurosurgical disorders. Prerequisites for vacuum structure use include adequate pelvic dimension, complete cervical dilatation, experienced operator, attached fetal head, more or equality to 34 weeks SD gestational age. Complications: vaginal lacerations from entrapment of mucosa between the stocker and the fetal head of the mother, neonatal cephalohematoma, and scalp lacerations as a life-threatening, subgaleal hematoma, or complicated intracranial hemorrhage. Rare, but in addition to vacuum duration, more 10 minutes, neonatal. Cesarean sections. The concept. Cesarean section is a procedure in which the fetus is delivered through incisions on the maternal anterior abdominal and uterine walls. Risks: maternal mortality and morbidity are higher than with vaginal delivery, mostly with emergency C-sections performed during labor. Maternal mortality frequently related to anesthesia. Hemorrhage, blood loss in double that of vaginal delivery, with an average of 1,000 ml. Infection. The locations are abdominal wall, endometrium, lungs, pelvis, and urinary tract. Prophylactic antibiotics can decrease infections. Visceral injury. Surrounding structures may be injured, bowel, ureters, and bladder. Thrombosis. Deep vein thrombosis is increased in the pelvic and lower region on limb veins. Uterine incisions. Concept. Low transverse segment. This incision is made in the non-contractile portion of the uterus. With a low probability of uterine rupture, the bladder must be dissected, lower uterine segment. The advantages are that trial of labor in a subsequent pregnancy is safe. The risk of bleeding and adhesions is lower. The disadvantages are that the fetus must be in a longitudinal position. The lowest segment must be developed. Low transverse uterine incision, less adhesions, and blood loss is safe, low risk of rupture in a labor 0.5%. Uterine incisions. Heading. Classic. This incision is made in the contractile fundus of the uterus. It is easy to perform dissection. Risk of uterine rupture both before delivery and during subsequent labor. We need to schedule a cesarean section again before the onset of labor. The advantages are that any fetus can be delivered, lower segment varicosities or fibroids can be avoided. Disadvantages are uncertain in trial of labor in a subsequent pregnancy, risk of bleeding and adhesions. Classic uterine incisions, risk for subsequent labor, trial more blood loss and adhesions, high risk of rupture, 5% in a labor. This is image the uterine incisions. Cesarean sections, indications for primary cesarean sections. Cephalopelvic disproportions, CPD, more frequent in indication of cesarean sections. It means that the pelvis is too small for the fetal head. In actual practice, it will most often indicate a failure of normal progress, dysfunctional labor or suboptimal fetal head orientations. Fetal malpresentations, commonly abridged presentations, but it also means any fetal orientation that is not cephalad. Category 3 EFM strip. The FHR monitor shows that the fetus cannot tolerate labor, but this is commonly a false positive. Cesarean sections, about elective cesarean, recommendations include women who are considering having more two children should know that a cesarean sections cause uterine scarring. This woman should avoid the primary cesarean sections. Women should not have a cesarean sections before 39 weeks of gestation. Women should receive individual counseling about the risks and benefits. Vaginal birth after cesarean, VBAC. Concept: successful vaginal delivery rate is up 18% in selected patients. Criteria for trial or labor include consent, not repetitive. Indication for cesarean sections, placenta previa, bridge presentation, anterior low segment, transverse uterine incision, and clinically adequate pelvis. Do you remember for your next D&C and episiotomy, these are some obstetric operations you need to include? Well, many thanks. Bye bye.